which is not so easily picked up if not explained to the patients. And what we see in the urban population over here is there's a lot of obese mothers who start their pregnancy very late in life, or even if they are younger in life, there's a lot of polycystic ovarian syndromes and infertility issues which are more related to GDM. And those mothers are the ones who visit the clinic more in the urban areas. So over here, when such a population comes, they are hardly aware of sugars developing during pregnancy. If it's a pre-existing sugar, they have a fair idea. But when they start off early in the pregnancy, when we test them, all the reports are normal, and so hardly expect that something could actually develop during pregnancy. And that is one challenge for us, to have it detected at the right time. You have two kinds of patients. One who is ready to do all the examinations and tests prescribed. They just want to be very sure and careful. In them, the challenge is not in detecting the problem. In them, the problem is to make them understand, yes, this can happen, and to take it calmly and to actually address the problem. They are quite scared when they come to know, I have a diabetes now in pregnancy. But there's other population. Like I said, we have a rural population coming in, and there's a mixed crowd. So for them to get the test done time and again, it becomes very difficult to convey that it is important. Once we've done the sugars in the first trimester, even that is the big challenge, to get all the tests done. And we have already committed these tests are normal. And then again asking them to do the same test in the second trimester becomes too difficult. So pregnancy brings about a lot of changes. So if there is a tendency, especially in people with an impaired glucose tolerance in the initial stage, or even in obese mothers, there is a hyperinsulinogenic, there's more insulin production and more glucose intolerance which develops as the pregnancy progresses.
That is basically because of the hormonal changes.
Exactly.
Pregnant.
And also the weight gain which occurs, which is very natural in pregnancy as the baby grows.
Okay.
Now for them, the one good thing about a gestational diabetes is, since it starts at 24 weeks, it does not affect the baby as such when it pertains to malformations.
Okay.
Because a frank diabetic is a high risk for fetal malformations too.
Okay.
So these people escape that part. But the other effects of diabetes in the later half of pregnancy becomes an issue. You have big babies, and these are the mothers who are also prone to cardiovascular risks, and also the babies have more water around them, the chances for preterm delivery, and sometimes an added risk of a smaller baby because of a cardiovascular risk associated. All these are well known. Infections during the pregnancy, and sometimes silent deaths of the baby during pregnancy, especially in the second trimester after all the growth is done, which is very, very scary during the second trimester and the third trimester. When we do the first initial screening for all, sometimes few of them can be picked up, rarely with an impaired glucose tolerance seen in the first trimester.
Okay.
But GDM is usually in the second trimester most of the time. So when I started off dealing with this problem in my clinic, I really had a tough time. It was not easy because when we start explaining, either the patient is too scared and they just leave the clinic and go for a second opinion, or just ignore the problem because it is not going to show up as anything in the patient initially.
Yes.
So they used to have a bad experience, and then when things are out of hand, it is very difficult to bring it back. But later, slowly we learn the art of conveying the message, making them understand it is important, at the same time not scare them away. So here we actually tell them the complications which can be possible in case of an impaired glucose tolerance, but also we give them a fair view that if you are going to follow so and so things properly, you will have a very healthy baby just like any other woman. And the best part is, most of the time the GDM vanishes post delivery.
Yeah.
So that is the good part.
But in how many cases will it happen that the patient becomes diabetic?
Even after the delivery, yes. That is also quite possible. There is around a 25% risk, a cumulative risk after 2 years post-delivery. So they have to be followed up yearly. They do have a risk later. It is almost like a diabetic diet, but we also take care that the nutrient is not removed from the diet, especially they are pregnant. The calories don't suffer either. So they are taken care of well by the dietitian for this purpose, because we are dealing with two lives when we are dealing with the diabetes in the mother.
And doctor, what is the kind of exercises that you recommend?
Simple exercises starting from a walk also helps. And if people can actually afford to go to some classes like classes done by physiotherapists during antenatal period, that would help. But if we start off with simple walks. And we ask them to be active, not be sedentary. Many times such patients are obese with a pregnancy, so they are very resistant to exercise. So we may have to motivate them more than others.
Doctor, what is the effect of GDM on the mother as well as the offspring?
Okay, when it comes to the effect on the mother, if the sugars are not controlled, they are more prone to perineal infections, vaginal infections. They are more prone to preterm labor and big babies, problems due to big babies, breathlessness, polyhydramnios, chances of PROM due to the same, and also hypertension in such mothers associated.
Yes.
So these things are quite common. More than that, when it comes to a diet restriction, it is not the problem only of the lady. The husband also has to take an equal part, because preparation itself is a big thing for them. Making different items separately for them and at multiple intervals is not an easy job for the lady, along with probably another child and one pregnancy. So I think the whole family has to support, which is counseled. And the second thing which is difficult for the patient to accept is the insulin therapy, which is started off at around the second trimester if need be. There's a lot of resistance to injectables. There are criteria for when to start insulin, when not to. When the idea is to get your fasting insulin glucose levels below 95. But in case the fasting glucose starts off at 200 or so, then we have to directly start off with insulin, because we cannot take the dangers of stillbirth and things like that. So, but here what happens is, initially if it's a borderline sugars which we detect at 24, we are pretty sure, because the cause is a pregnancy, such patients are going to have an increased sugars as the time goes by. But in the initial period, we do ask them for a diet control and minimal exercises for at least a 2-week period. Okay. And we keep monitoring the sugars in the meantime. If they are under control, then we ask them to continue on the diet control. Such patients who can be managed completely on diet usually do not end up with complications much. But you have another group which is so common that eventually, maybe at 24 weeks, their sugars are normal. But as the pregnancy progresses, they may slip into the abnormal side, even with the diet and exercise. Then you don't have a choice other than starting insulin for them. And insulin is one of the better therapies, because you can actually titrate the dosages depending on the different sugar variations during the day. So I think it is a comfortable therapy.
And what kind of oral drugs are also recommended for GDM, doctor?
Okay. Actually, the drugs which enhance insulin secretion are not recommended in the books. But some countries and uncharted people do try glibenclamide and things, other medicines which cause insulin increase. But ideally, I don't prefer using them. Metformin is the only one which is used sometimes along with insulin, but most of my patients, if at all required for a GDM, are on insulin therapy. The amount of obesity which we see around actually increases the number of infertiles, the PCOS, and that itself pushes people into the type 2 diabetes group, or at least the impaired glucose tolerance group. I think the physical activity part is not given enough importance in our country. And also, if at all a lady has been diagnosed with impaired glucose tolerance in the first pregnancy, it is seen that if they can exercise, bring down their weight, and especially the abdominal girth in between 2 pregnancies, even that helps. So I think more of impetus should be given on that front. The awareness and the government to actually encourage all this from childhood is important in the schooling. If it is a pre-pregnant patient, sometimes people do come for a preconceptional counseling. We always stress on the fact that please reduce your weight. You won't lose much in 6 months. So you please reduce your weight and start off your pregnancy in the best possible environment. That is a very worthy advice which we give. But many a times
you cannot control obesity during pregnancy.
Yes, it is quite difficult. You may not increase to the amount it might increase otherwise, but you cannot ask them to lose weight during pregnancy. You can make a change in the diet. Sometimes if they start off with an obesity, we don't recommend them to increase weight at the same rate at which a normally weighing woman would increase. but still they won't be in the weight loss pattern, obviously, because we don't want to compromise on the nutrition. If things are done before the pregnancy, it is always useful. But once in pregnancy, you don't have much choices other than following a particular diet, a few exercises, which are not very strenuous either, and obviously therapy. Somehow in our clinic, I have seen that nowadays you can't even keep that criteria, because even young mothers are quite obese.
Exactly.
So it has become more difficult, and that is why we have this universal screening. Earlier it was thought many years back that probably only the high risk mothers should undergo the screening in the second trimester, because they would be the ones who would suffer. But after looking at these cases, more and more of obesity in the urban population, I think it is worthwhile, and that is why the universal screening is applied. But one good thing which the government has done is, because our country cannot afford all these hi-fi tests, which is very expensive, like HbA1c, because they require more expertise also and more money also, and we keep asking them to do time and again with all other tests, probably people will not come ahead. So here they have kept easy tests, like 2 hour after having 75 grams glucose, we just ask for one sample, because once the lady walks in and then you make her go back and come back for a test, probably she'll never come back. So although we recommend doing the same glucose tolerance test for 3 different stages at 24, 28 and 32, still the whole cost doesn't grow.